So we are live in 5, 4, 3, 2, 1. We are live now.
Thank
Sir,
you.
you can start.
Thank you. Olecranon fracture, avoid day one failure. We are all familiar with this tension band wiring. I think last time I also mentioned about the Olecranon osteotomy. How to fix it? It is more or less the same principle when there is Olecranon fracture fixation. As you can see, the wire goes anteriorly and onto the ulnar side, and two knots or one knot depending upon the individual fancy. Now the main thing is, first make 2 cuts in the triceps. Now you put in the wire, either here or as I mentioned, anteriorly. Then bend this and bend it inside, and then put a wire, put a circlage underneath the triceps. Then you can have these 2 things, 2 loops or 1 loop, depending upon your fancy. And this comes out anteriorly and on the ulnar side and not on the lateral side. Long intramedullary wires also will not come out if they are under the triceps, which is better if it has been put like this. Not like this, but it has to be flush to the bone so that it will be underneath the triceps. And that is from these 2 holes, you push it inside and then hammer it inside the bone. Then they will remain more or less stationary. Now this is what is the 1 loop. 1 loop you can do it, or 2 loop you can do it, whatever is acceptable to you, but you should not have the laxity over here. I think today only I'll show you one case where patient had a problem purely because of it was lax. And since it was lax, patient got the problem, and this is what it is. You can see this?
Yes, sir.
You can see that I have not done anything. This is how the wire was. And that's the reason why it was hitting it on the skin. And so only because of that, we had to remove this wire. This laxity has to be removed. And if it is too thick and it is not elastic enough, this will not be left. So this is what you should avoid. Now, these are the Olecranon fracture standard treatment, which you can put it through this tension band wire, and you can put this tension band wire, 2 things which is there. Now, some people use this screw. As you can screw compression depends upon thickness of this medullary cavity and thickness of the screw. If the screw cannot progress further because it is too tight, you will get a distraction there. And even if you can see the screw, once you go on tightening it, it will, since it is not progressing further, it will go on increasing the distraction. That is again a screw you put in, and then you put in the tension band. So once you put in the tension band, and if it is not going there, there is going to be a gap over here. So this is the one why the screw is very dicey. I never use the screw because I find the screw is a hit and a miss situation. Severe comminuted fracture like this, though they got a good reduction, but this is a very poor construct. As you can see, first, obviously because of this much of comminution, he could not put the K-wire anteriorly. So they gone intramedullary, and they have not got under the triceps. Good circlage, good reduction was achieved, but in a short time, the wires walked out. Once the wire walked out, then this tension band device alone is not going to be enough. This is how it went into non-union. And ultimately, it was treated like this with the hook plate. And this is the way in which ultimately he got a good result. Such fractures, tension band wire is out. It has to be a hook plate, or it has to be a Olecranon plate, which is there now. That is the one which will give you a good fixation. And that is the one which is there. This hook plate, I had devised many years back, and it was being used as a Tanna's hook plate. But unfortunately, more and more people copied it, And this hook plate, instead of becoming like this, it became like this. So it would not go in and it will not fit in. And that is how the whole thing went on. Ultimately, it is not available today. Very easily, I understand. This is a comminuted fracture. Tension band is not always ideal for such a comminuted fracture. For such fractures or such fractures. Plate may be better off in such fracture. Maybe, or I'll say it is a better fixation than the nail. Now here is the fracture, comminuted fracture, you can see. So the plate is the one. So you put in the plate. Now this is the plate I was saying that they have modified this plate and it has become like this. And from here you can put in, I'm putting a tension device. I'm putting with the tension device, I'm not compressing. I'm actually trying to extract it out in order to be properly here. And once it is extracted out, then you can tension it and then you can get the things going. But this is not a very good reduction. So this is not the ideal situation. And the main thing is the hook, which I mentioned to you, modified hook, which I think I was trapped on the table. This is my own case. So ultimately I relied on this screw, which is not intra-articular. It can go from here to here, it can go, it will remain extra-articular and it can have a good fixation. So here is the screw. This is the screw, which is a good fixation. This is the second, again, the hook plate, which was copied by somebody else, was like this. So all these are the copies which are there of the hook plate. And I feel that I don't think any one of them are working. So if I can go original hook plate, which was there, this was the original hook plate, which I had done it from the Olecranon and anatomy and bending, how much bending and everything. And then ultimately it became this modification and this modification. Anyway, fortunately, it's not available and it is not required today because the Olecranon plate and the other better hook plates have come. So this is not reached, though it is being sold at times in the market, but this is not required. This screw is best hold. All what you have to do is to first put in a K-wire. Confirm that it is extra-articular, it is not going inside the joint, and this is where it is going. Then you can put in a K-wire, confirm C-arm, cannulated drill, screw just crossing the bone, avoiding the articular cartilage, and not too big. This screw is a bit too long, so it will hurt again here. Now, here, this sort of a fracture, now the Olecranon plate which came in, so the reduction is the most important. The screw from here to here is the most important part of the screw. As you can see it over here, this is the screw, which is a reduction screw. It is a leg screw you can put in, and the leg screw, which gives you a good compression. And then the whole Olecranon plate is there, it's putting in, and you will have a good fixation of that, and this fracture heals up. So again, all these fractures, it needs this compression and this going into the this angle, depending upon not intra-articular outside. And as you can see, this is the one ultimately patient has a good traction and she can move about and walk about. Now here is a badly comminuted fracture. Again, there is no question of putting in a tension band. So the treatment is, again, this screw, the leg screw, which is reconstructing the complete elbow joint. And then it is neutralized with these plates and screws and few plates and screws. And then this coronoid leg screw is the most important screw. And other screws, and you can see here, good flexion, good extension. This you can see on the video, which also goes on. So it is a good range of movement you can get. So there is not necessary that you will get all the time a poor function if it is badly comminuted fracture. This comminuted fracture, you can see here, you are putting this thin plate because this is before the Olecranon plate arrived. There is a fracture here and a fracture here. As you can see, these two fractures. So this was the small thin plate which was bent. This is the main screw which is doing the job. Then neutralizing plate and the second plate. And ultimately, excellent range of movement supination condition could be achieved. So as you can see, these are the simple plates, but the leg screw is doing the job. Leg screw is the one which is there. And here, as you can see, these are only the thin wires which are there. Now here is the one again, second thing, leg screw. This is the leg screw. We have seen this already. Now, such a badly comminuted fracture. You can see it in a AP view, and this is the lateral view. So you can see this will be stabilized. The Olecranon fossa has been completely distorted. So this can be treated now with these two leg screws. These two leg screws, and the whole thing has been reconstructed. And typical Olecranon plate which comes in, it gives the thing. You see the Olecranon plate is slightly proud here. Again, such a bad comminuted fracture. Again, you can see the same imported Olecranon plate, but it is proud here. This has been fixed, and ultimately things become all right, but this is proud here. So now the Olecranon plate, which is there, which has to be put is, because this is put on the triceps. So triceps is attached here. Now you put it on the triceps, it will always remain proud, and this will hurt it. So I have been doing this is, I cut the triceps, plate has been shoved in, plate goes in inside the triceps, and then put the triceps back there. And this is the way in which this plate will now be on the bone. So if you need it, you can bend this plate till the time it hit the bone, put the screw, and allow the triceps to fall back. You may not be able to stitch it up, but it will fall back, and ultimately it will heal up. So again,
excuse me, sir.
Yes, please.
So in the last slide, when you get such type of fracture where there is previous to this one, where there is Olecranon fracture as well as proximal where radial head fracture, or maybe whether to do radial head replacement or radial head fixation, that is another topic. How do you approach this? By midline incision or two separate incisions?
I'll explain to you. This is not an unstable elbow. This doesn't become like a terrible triad. So head of the radius is fractured, Olecranon is badly comminuted, but the elbow is not dislocated. So in this situation, the ligaments are intact. LC8 and MCL2 ligaments are intact. Now here, as I said, today's scenario, we would replace this head. I agree. But in this situation where the ligaments are intact, you can excise the head without any hesitation, and you will not have any problem at all. Only thing is... So
what approach, which approach, midline posterior or dual approach?
We will have to do midline posterior and probably a separate approach for the radius. But here, this is, I don't think this is my case, but this here, the surgeon has done everything from one approach. As I said, at this time, I remember I was debating whether why the head was not replaced. But since it wasn't unstable, he has not replaced. But only thing is, I would have fixed this coronoid piece over here. He has left the coronoid piece and there is no one screw here. This is the screw which should have come. And this is so far off. So that's the reason these situations. Any other questions on to this?
Sir, in such scenario, where the radial head is comminuted and the Olecranon is fractured and the elbow is stable, if I do a two-stage surgery for radial head excision, just to avoid interference and development of a myositis ossificans in the brachialis muscle, is it an prudent approach?
Deshpande,
yes, sir.
Is, when you go down second time, you will have to remove that head of the radius which is malformed. It is united.
Yes, sir.
And your purpose of keeping it originally, if there was a dislocation, is then perfectly justified. If the head of the radius is there and the dislocation is avoided, that is perfectly all right. But into the stable construct like this, I feel either you replace it or excise it, it doesn't make a difference.
But will it increase chances of myositis ossificans?
It's such a comminuted fracture. You keep the head or you remove the head. Because the removal of the head is very simple. From the same approach, you can go slightly deep and take it out. But here I would another approach because it is very simple that you can just go down and you will be able to just take out the thing. Here you will damage things far more.
Yeah. The flap is very much raised on in this approach.
That which will be raised.
Yes, sir.
Again, this is badly comminuted fracture. Again, you can see the same thing. This has been filled up. Leg screw. Leg screw is reconstructing the coronoid. These are the screws which are going. This is ordinary plate. You can see this.
Yeah.
And been able to reconstruct the whole thing very well. These are the bone grafts which have been put. Hydroxyapatite bone graft which has been put. Now here is the other fracture. You can see it was a coronal split. Once it was a coronal split, which was probably in the X-ray, it wasn't seen. We knew that there is a fracture. The AP view was not very clear. Once I went down, this is how the fracture was. So it was very simple. Just reduce, put in a leg screw. Put in the leg screw, the fracture is reduced and neutralized with the semitubular plate. As you can see, this has been ordinary semitubular plate is going to neutralize because the leg screws are there. This is going to be a very stable construct. Any questions up till now?
Sir, in the case which you showed, there is a fracture of Olecranon and the ulna proximal end. The ulna segmental, that means.
Yeah.
So which fracture to be fixed first? Whether you go and fix Olecranon first or you fix the fracture ulna first?
I would fix up the Olecranon first.
Articular reconstruction.
Articular, because all the efforts have to be put into that articular reconstruction, because then other things it will fall back very simple.
Quite logical, sir. Thank you, sir. Yes, sir.
You have any other opinion? Dr.
No, sir. No, sir. I would go in the same fashion, sir.
Now here it was very simple, as I said. Now, any reason why this failed?
Wrong choice of implant.
Yeah, because see, this is now not a Olecranon fracture. This is upper end of the tibia fracture. Upper end of the ulna fracture. Now for this fracture, this plate is very thin comparatively. And here you have got two half screws and this is the one screw. So for this sort of a fracture and there is a comminution, I feel you need more stability. So this broke down. This broke down, you can see very well.
So we should have done dual plate over here.
Or as I have done it here just now, this is what I have treated. I inherited at this stage and this is what I treated. This was how it had fractured. And I treated it plate on the side of the ulna, so that you can have two cortices fixed on all of them are two cortices.
Bicortical.
It is not onto the dorsum, but it is onto the side. Once it is onto the side, you can see it is a bicortical screws fixation, and this is a solid, strong DCP plate. Once this DCP plate has been put, you can see the whole thing is completely held up. Because there was a good fixation proximally, good fixation laterally, and proximally and distally. And this is what has a thick plate which is there. And this is a typical, I do this, a bottling screw, which is a slightly oblique screw at the end in order to avoid stress riser. Whether it works or doesn't work, still it is to be proved. And this is the one which ultimately held up. Now here is the one fracture, which was a comminuted fracture. Olecranon things per screw, and 1 year it held up. And this is why I think this is what we see. That this is the incision I take it is always like this. It's never onto the Olecranon, because that is the one which gives quite pain there.
Sir, how do you make sure that the screw is fixing into coronoid process?
It is only radiologically. That's fine.
Yeah. It is only radiologically.
Because there is no way to really confirm otherwise. So in a few different views, you don't want to go further also. So it is pure radiological.
Okay, sir. Fine.
That screw makes the whole fracture fully stable. As you can see, such a combination fracture. One screw here and everything is in a good shape.
So the position of the patient is lateral or supine and arm over the chest?
It is on the part, it is a lateral and the arm is there on the side of the table.
Okay.
Because you have to go posteriorly, no? There is no other way.
Yes.
That is the most comfortable approach. In fact, if you take arm over the chest, your sterility is not assured. You cannot assess everything. Whereas if you hang the forearm down, you can have more range of movement. You can extend it properly. Everything is in place.
Those of you who do not know, Dr. Deshpande was there in the last course. He attended almost 80-90% of the times. And his enthusiasm of coming even now and contributing, I appreciate it very much, Deshpande.
Thank you, sir.
Now, this is the...
Sir, I have a question. Sir, hello.
Yes.
Sir, I have a question that if you can tell the CM position and patient positioning in the OT, if you have any picture or any video of that, because most of the time we have a difficulty in putting CM with the patient on side.
You can put a wooden plank.
Okay, sir.
I put in a wooden plank which goes underneath the bed and it is really jutting out on two sides wherever you want to jut it out.
Okay, sir. Thank you, sir.
Now we come to this rare operation. Excision of the ulna. This is a small fragment in a comminuted small fragment in an osteoporotic bone. It has been recommended that excision of this piece is a better choice rather than fixation. Please see the subset which I am talking about. Comminuted and severely osteoporotic fracture, which you try to fix it, you will not be able to fix it adequately with anything. So select group elderly piece less than 50% osteoporotic, too small and too comminuted to fix. This 50% is the highest extension. We talking about Olecranon from here to here is 100%. So what is being accepted is if you have the 50% of the Olecranon, you can excise. I have not been able to have that guts of 50%. I take only about 15, 20, 25% maximum is the excise. Otherwise, I repair it. But the literature talks about 50% of the things you can still excise it. And the way excise is, again, this is the same approach. This is the whole triceps. Take the triceps away. Triceps is taken away. Take out this piece and put the triceps back. Put the triceps back and stitch it up. So your triceps, which has been tongue of the triceps where the bone is, you are excising. All the side aponeurosis and the attachments are there. And you put back the tongue. This is the way in which you will be able to fix it up. I have done only one or two. I have not done many. This has been described in the literature, but you can see it is a small piece with this because it is difficult to fix up such a fracture. And then you can get this stitching back. Facial flap is replaced and complete extension of the elbow for a tendon repair. This is mandatory. And that piece which you put in the bone, it has to be more anteriorly than posteriorly. If it is posteriorly, it is not functioning. So you have to put it more anteriorly. After the excision of triceps attached, adjacent to the articular surface. More anteriorly adjacent to the articular surface. Indofay and Howard 31 reported good to excellent results in 11 of the 12 patients with adequate follow-up after excision of as much as 70% of the articular surface. It's quite surprising, 70% of the articular surface. Because they are talking about the LCL and MCL and all are intact. So the elbow dislocation chances are not that very high. But you can see the cases. They are talking about 11 to 12 cases. Sorry.
Sir, it sounds unbelievable, sir.
Yeah. Post-op arm pouch or a temporary posterior plaster support, pain in about 2 days, and start active mobilization exercises. Arm pouch to be kept for 10 to 15 days till pain. No passive mobilization. Movements take 4 to 6 months to recover. Last 10 degree of movements may not regain. Now, this is another fracture, tip of the ulnar fracture. This is the triceps tendon, which is attached here. So tip goes out and the triceps tendon takes with it. This is a small tip fracture.
Sir, slide is not moving, sir.
That you feel. Sorry?
Slide is not moving, sir.
Now it's not moving?
No, sir.
Reshare again.
I think I'll go out and come back. Can you see my slide now? Can you hear?
Yes, sir.
Yes, sir.
Right tip of the Olecranon chip.
The slide is not visible yet.
Slide is not visible.
Also,
I can see.
So it's visible.
Visible, sir.
Yes, sir. So now
it's visible.
Yeah, so this is the tip of the Olecranon. Small tip goes along with the tendon. Small or big tendon. If left alone, then there will be a loss of subtle power of extension. CT MRI diagnosis, clinically, it is the one once you suspect, you will be able to diagnose this. Tension band through the osteotendinous junction is the treatment of choice. Now here was that small fracture. You can see here, this is a small fracture. This is how once I opened up, this is how there was a big gap and that bone piece which was here.
Recording. Is it clicking red? Yeah, clicking red. Recording is does that change? Recording. So I stitched up this triceps, stitched up the triceps, and things became perfectly all right. Here is Dr. Sangeet's case. 30-year-old presented with pain in the elbow following a fall playing cricket. Almost full but significant weakness of the triceps, of the extension. This was the piece. This is the CT scan. You can see the CT scan. This is the X-ray. And this is what was the fixation of the bone fragment. This was a bone fragment. This is the triceps which was there. A little bigger type of a triceps had gone. So once it was fixed up, you can see this is how it is a good range of movement. This is what it is before the pre-op. You can see the paper. This is the pre-op.
So tension band is ideal, most fulfilling. Two loop preferred, K-wire in the antecortex ideal, but not always possible. Early backtracking of the K-wire if it is in the center and if it is outside the triceps. Plating is when required, there is no option at all. And excision, I feel, is underutilized. And do not miss out for small pieces of bone, which you see there, small avulsion from the triceps. That is very important that you don't miss it out. Now, any questions on this?
So triceps reattachment can be done with suture anchor or drilling also, or reattachment?
Anything it can be done. Here, as you can see, when I removed, all this triceps was around.
Sir, what is your indication for dual plate in fixing up of an Olecranon?
Is it flicking red?
Sorry?
Sir, what is your indication in using double plate or dual plate for comminuted Olecranon fractures?
Generally, I don't use it because I think there is hardly much of a, you will be really, Olecranon is too small a bone. So generally, I don't use a double plating. But if there is a gap and if there is a problem which is there, then I may use a bone strut, either intramedullary, which is not possible in ulna very much. So I put it extramedullary outside. I show you one of the case like that, which is there. But because the double plating in the Olecranon, when you put in, you are almost destroying all the osteogenic area because there is hardly any bone which remains. But if you can put in a double plate with the midpo one side and other side with the reductions and all, I feel it should work all right.
Sir, if your Olecranon is severely comminuted, what we do, sir?
Yes, Dr. Deshpande, you have anything to say on this? Dr. Deshpande? Sorry,
Yes, sir.
Somebody asked the
Yes, sir.
Bolo.
Sir, please say again.
Sir, if Olecranon is severely comminuted, not able to plate it, what we do, sir?
As I say, double plating is generally not needed. See, all the pieces you will be able to really put them together, and it is like a bypass plate. 2, 3, 4 screws into the tip there and bypass it and put few screws lower down, and you will be able to do that very well without really touching those comminuted pieces, as I had shown you in some of those cases.
Okay, sir. Thank you, sir.
As you can see, this is the comminuted fracture. And as you can see, this was the fixation, one through there, and then whole thing has been kept open. Same thing can be done for all sorts of a comminuted fracture. You will be able to treat the same way. But comminution in the Olecranon is all pieces, they fall back together under traction or under distraction. So that's not a much of a bigger problem, you can see. Any other questions before we proceed?
Yes, sir.
You can see here also the same thing. This badly comminuted fracture. I put
Yes,
in
sir.
to reduce this, and all these area has been filled up. So one screw here, and one screw here, and the remaining screws.
Yes, sir. Thank you, sir.
Follow any other questions? Anybody wants to share or any suggestions or anything? Dr. Deshpande?
Thank, sir.
Any other faculty is here?
Seems nobody, sir.
Not yet.
Not yet.
So in proximal tibia fractures, I had a few queries. I have selected a few questions to ask in extra articular, not for the topic that Dr. Jignesh will be covering. So can I share?
Yeah.
Okay, sir. I will be sharing in just a minute. I am logging in from my computer.
क्या हो गया तो?
So my slide is visible. Sir, in extra-articular tibia fractures, I have faced 2 or 3 problems very frequently. Though results are good, patients at the end mostly are satisfied, but 3 problems that I faced. First, in like left-hand corner in this X-ray, like here in this X-ray on left side, the plate gets upwards, especially while using raft plate. So first issue is when to use this plate, raft plate, and when to use the hockey plate with thicker screws. Second is when to use dual plates. Like in this X-ray, there is a slight varus. In this also there is slight varus. Second, the plate gets lifted up after 2 years or 1 year or so. And like this also in X-ray, there is the plate on the plate after 1 year is at superior border of the joint. Though the patient is currently not having any trouble, how to decide the uppermost level of fixing plate intraoperatively, when to use dual plates, and how to prevent the superior migration of the plate.
Believe that this plate was originally lower down and afterwards it has gone up, unless the plate is bent, which is very thin, because the screws are holding. If the screws are holding, how the plate has gone up?
Collapse at fracture site. Collapse at fracture site.
Then when to add second plate, like here there was no collapse in this X-ray. There is no varus. So one of my seniors always puts the plate medially and there is no plate laterally in extra-articular tibia fracture.
I would put plate also medially here. To be on the safer side, that is a mid-pole plate. 2 screws above, 2 screws below, and that's going to be good enough.
So, but dedicated medial plate is not available. Posteromedial is available. Anteromedial plate is also available, but mostly long plates are of this construct or raft this construct.
On the medial side, even ordinary plate will be all right.
So, sir, like here there is a varus collapse. So, in this, we should have gone with single medial plate or dual plate.
Doctor, I think where my rule is on this side. On this side, there is a fracture which is going here. So I will put in a plate here. Unequal plate, I will put it here.
Okay, so dual plating.
thing is here. I'll put in a plate here, 2 screws here, 2 screws here.
Okay.
Because you don't want to economize on this plate at the cost of the virus, which is now, if we get the virus, that means you will have to do another operation to really correct the virus.
Yes, sir.
If you have operated, you will not do it, or you will not advise it.
Yes, sir.
And he is destined to have this early osteoarthritis. I would strongly feel that in fracture, which is only the lateral plate, is very rarely required into those small fractures. But if it is a comminuted fracture, like a fracture in this, I feel it is much better to have a dual plate rather than a single plate.
When to use the 6.5 screw plate, this one, and when to use raft plate?
When in doubt, you just put in a small thin plate. All what you need is 2 screws here. 2 screws here. It is going to be only a percutaneous plate.
Okay, sir. So dual plates is always better.
In such fractures, it is safer. It is maybe an overkill at times.
Yes, sir.
But I feel it is safer to do that rather than to leave it just like that. Do you have any opinion, Dr. Deshpande?
No, sir, I agree fully. Only my concern is, sir, whenever we place one plate, it becomes a cantilever type construct. And in a cantilever type construct, the stresses are always more on opposite side. So I do follow this dictum. I put 2 plates, sir.
So in this kind of fractures where there is intra-articular combination and we compress it proximally with condylar reduction clamp. So though the X-ray looks okay, but I know that there was over compression.
Right.
So how to prevent that over compression? Due to the over compression, there was a beak posteriorly. This beak was not reduced.
Now, this beak we have not reduced. It needed a posterior approach. By compression, it would have never come. You have not gone posteriorly. It needed a posterior approach.
This beak was there. Articular reduction was okay, but I over compressed it. So what I feel is that
if you had done the and you would have realized this is a posterior piece and you had to go posterior laterally or posterior medially and you had to do the buttressing. You have not done the CT scan.
No, the CT scan was done. I don't have the images right now. What CT scan was done. So,
and you cannot miss this because this piece
yes,
is a well good lying posterior plate there. When you see the CT scan, you will be able to see it on the medial side. Probably this is how it will be. So you need a posterior plate here. I think the main
may I have joined, sir. Good evening, sir. Jignesh Pandya.
Bolo Jignesh. We are discussing this.
Yes. Sir, this medial plate should be posterior medial. That's all.
Yeah. Because this you have put it bang medially.
Yeah, this should be put posterior medially. Then matter ends. It will be perfect.
It is on the border. Actually, I should have gone on the shaft part. It was put on the border of the tibia. That's why.
Yeah. See, this apex is not reduced. That's why this is the problem. You have to reduce the apex. This condyle is rotated actually. You feel that it is reduced in a compression board, but it is not. It is actually the condyle is rotated.
And this is the one you will never get a result which is good result.
Yes, sir.
It's very simple. This same plate which you put it anatomy, which medial side, if you have done posterior medially, buttressed it, then you will be able to reduce this there completely.
And in these extra-articular fractures like previous
Just got, I think PCL also. PCL is also there, probably. If you go previous slide.
Yes, sir.
There is a PCL. Probably there is a PCL. If I can go this there, yeah, this is the PCL.
Yes, please.
If you see anything elevated here, that is PCL. always, by and large. The elevated means you have to fix it. It is 10 millimeter.
Okay, sir. And one question that is still not answered: when to use the hockey type of these plates in extra-articular fracture, and when to go with these raft type of plates?
Raft plates are basically to support the depression type of a fracture. That's the place where we use raft plates.
Okay, sir.
And if you are having completely a metaphyseal fracture, wherein the articular component is not there, you can get away with a hockey type plate.
Okay, thank you, sir.
You know the meaning of a raft. It is like a boat when it is being supported. That is the raft plate.
Yes, sir.
I think Dr. Jignesh is going to talk about all these things.
Sir. I am stopping. I am now unsharing the slides.
Yeah. Okay, Jignesh, you can take over. Jignesh?
Yes, sir, I can take over. Hello.
Before you begin,
yes, sir.
This is Dr. Deshpande from Ahmednagar. I have attended your earlier sessions.
Okay.
Yes, sir. I really wish to join any of a demo course for proximal tibia, wherein you are a faculty and you are explaining us a posterolateral approach. Or I am ready to come down to your place, fly down, walk down, drive down to see the case you are doing, sir.
Anytime, sir.
Kindly give me an opportunity, sir.
Please, sir. I'm absolutely obliged for kind words.
No, I'll be obliged to learn.
Definitely, sir.
Dr. Deshpande?
Yes, sir.
Can you hear me?
Yes, sir, I can hear you, but I can't see you, sir.
Yeah, Jignesh is a traveling surgeon.
Yes, sir.
I will come there.
Sir, it will be. Sir, मेरे लिए तो बहुत बड़ी बात होगी. मैं तो उसका लाइव डिस्प्ले करूंगा सर ऑल ओवर महाराष्ट्र.
Yes, sir.
कब से अहमदनगर कहाँ है वो थे?
महाराष्ट्र में सर.
सर शिरडी के नजदीक है सर.
शिरडी के नजदीक है, बहुत बढ़िया.
Okay.
Okay, sir. Should I start?
Yeah.
Okay, sir.
There is one chat. Let me see. Gopal Yadav is saying, please give tips and tricks for distal locking after femur and tibia nailing, as it takes a long time. We'll talk it sometime later.
Can you see my screen, please?
Yes, sir. Yes, sir.
Okay, we can. Okay, fine. So, sir told me that I have to take up something like everything around the proximal tibia. So, what I divided this part into medial condyle and lateral condyle separately. And we will take first medial condyle fractures and its variants. So, you will come to know that what are the types of the medial condyle fracture and how it can go to lateral condyle also. And then we will take posterolateral condyle approach and cases, and then we'll take a frost approach, right? So I have divided the. Yes, sir.
Show your handsome face, please.
Okay, I am not very handsome person, but still. Sure, sir. Okay.
Not yet.
I have already started. Next time. I don't know whether you can see or not. Let's just I have made the camera on, but I don't know whether you'll be able to see it or not.
No, Jignesh bhai, this mute, unmute and start video आप वहाँ जाके करो.
हाँ, उसी में किया सर. स्टॉप वीडियो में से वीडियो स्टार्ट कर दिया है.
चलिए हम आपको YouTube पे तो देखते ही रहते हैं.
Okay, sir. Okay.
Yes.
So, okay. So, we'll go for first medial condylar fractures and its variants, right? So, learning objectives from this talk will be, you will be able to identify medial condylar fractures and definitely understand the fracture geometry. I have got ample number of cases to show. Recognize associated ligament injury like ACL or PCL associated, very commonly associated with medial condylar fractures. 97% incidence. And you will recognize associated posterior condyle along with the medial condyle fractures and how to plan a treatment for this type of impaction and fractures, right? So there is anatomical peculiarity of medial condyle fracture tibia. It has, you will observe that it is eccentrically located. So its weight-bearing axis, when it passes through it, it is varus, right? And it is not in line with medullary canal. When you do tibia nailing, by default, you go to lateral side. If you go on medial side, you will hit the medial cortex. So it is not in line with medullary canal. It's triangular cone-shaped bone for and it's prone for severe fractures, and it becomes part of the fracture dislocation or subluxation very commonly with when bicondylar tibia fracture occurs. So you will observe all these things in your practice also if you remember your cases. So that's why the medial condyle is not in line with the femur. That's why it got severe fractures. Lateral condyle is convex and on the line with the axis, so it causes compressive fractures. Lateral side as a fibula as a support. Medial side there is no support. Medial quadral ligament attaches to the medial condyle. Lateral quadral ligament doesn't attach to lateral condyle; it is attached to fibula. So that is the difference in the fracture pattern of both the condyles. When you hardly see split depression or a compression fracture in the medial side, you will always see a shear fracture with the medial, anteromedial, or posterior apex. But you will not see such same pattern fracture on the lateral side. So that is why we will see different type of the fracture on both the sides. So no support like fibula is a lateral condyle. It's cone-shaped triangular bone, and it can have apex medial, posterior, anterior, according to the shear forces and at the time of injury, where the knee is. If the knee is in extension, apex will be medial. If the knee is in flexion, so according to variable degree of flexion, the apex will move from posterior to anterior. I will show in the cases. So this has changed the things, I think. 2013, Leo Confine has described this tibial condyle fracture into medial condyle, lateral condyle, and posterior condyle. All classifications are new classifications, all around these only now. The posterior condyle has two parts, posteromedial and posterolateral. If we understand these two components properly, then how this posteromedial and posterolateral, from the center of the intercondyle eminence, the one line goes to posterior border of MCL, that is posteromedial condyle, in the center up to PCL, and posterolateral condyle is anterior part of the head of the fibula. That's a line. This is how it is bisected in both the parts, right? And Giglio, typical pattern. Posterolateral condyle will be compression fracture, depression fracture. Posteromedial condyle will be a shear fracture. So, and we will see both together in coronal plane fractures of the tibia. Now, this is the case. Simple case. See, this is medial condyle fracture with posterior apex, right? Somebody tried to do with antero-posterior lag screw, anterolateral to posterior. The thinking was right, but this lag screw cannot reduce the fracture, cannot hold the fracture because it is a shear type of fracture. It needs buttressing. So this as understanding is right, but execution is wrong. What has happened, you can see. This is the outcome. Simple fracture, bad outcome. Another case. Surgeon understood the fracture very well. He put the plate posteromedially, but none of the screw is in the proximal fragment. So it has allowed secondary collapse. You can see in follow-up, the fracture has totally collapsed, 2009 X-ray. Another one, medial condyle with posterior apex. Simple again. Lateral hockey plate on medial side. Wrong plate on a wrong surface and the wrong execution. So it is just, you can see the X-ray, pre-op and post-op frame X-ray with the plate in situ. So do not use lateral side implant on medial side. They will never fit well. They will never hold the reduction, and this will be the situation. And you can see exactly the posterior apex is out, and everything varus and everything is remaining there. So this is not a good idea. You understand the fracture very well, plan your treatment, and you can get a perfect outcome. So this is again a coronal plane fracture. Can't be treated with a medial plate. It will not hold or reduce the fracture. You need a posterior buttress plate from posterior medial approach. So what happens is exactly, this is posterior medial condyle fracture, right? Anteromedial plate, if you put, no screw will hold this fracture. It will just go like that. Not a good idea. Another one, raft plate. People say that from raft plate, the posterior screw can catch the posterior medial fragment. Not possible. None of your posterior medial, none of the raft screw will hold posterior medial condyle fracture, even if you reduce and hold with the clamp. You have to have it is a severe fracture, one more buttress plate posterior medial. So not a good idea. Lag screw. Lag screw principle not applicable. Screw cannot pull the fragment or hold the fragment. It is a severe fracture. It needs buttressing. So this is again not a good idea. So it's not applicable, right? Now, what should we do? Go directly posteriorly, reduce the apex, reduce the condyle, put a plate in this manner. So your plate will be like this. You can use any type of plate, but in a buttress mode. It can be a T plate or it can be a classic anatomical posterior medial plate. Either way, if you're comfortable with, you first screw at the apex, compress the fracture, then rest of the screws. Now, these are the two fractures, right? These are both are medial condyle fracture, but one in AP plane, one in coronal plane. So one in sagittal plane, one in coronal plane. So this is fracture line, intercondylar apex, medial, Volquist. We'll see the types again. So it is type B fracture through the intercondylar notch. Apex is medial. Simple. Medial plate. And right side, coronal plane fracture. Simple. Posterior medial plate. Both the plates are buttress plates, but the surfaces are different according to apex of the medial condyle. So this is coronal plane intra-articular fracture. This is sagittal plane intercondylar fracture. So actually it is intra-articular fracture, but none of the condyle is intra-articular fracture. It is through the intercondylar eminence. Now this same. So this severe fractures, what they need buttressing. Like you can see the steps. First plate, then first screw, then the rest of the screws. And there is the post-op X-ray. So it will make absolutely perfect reduction, alignment, stability, and you can mobilize the patient. Now we see, this is an X-ray of 18 lateral X-ray of the tibial condyle fracture. So this medial condyle fracture. There is something apex in lateral view. AP view, you can hardly visualize the fracture. But suspicion is the best diagnostic tool. Even if you want to treat conservatively, get a CT scan done, confirm what is the fracture, and then decide. Now, this is 2D CT, and that is 3D CT. This is, what is it? It is ACL, medial condyle fracture. It is a complete medial condyle fracture with posterior medial apex. It is a posterior condyle impaction. So these three elements are there, but two doesn't require address. ACL level then is mild in position, and posterior condyle impaction is very minimal. So I will treat only medial condyle. Just bend posterior medially, did posterior medial plating, simple 3.5 plate, and you can see the outcome. Perfect reduction, fixation, and full function. So if you understand the fracture very well, plan our treatment, we can get excellent outcome. Now, this two type of fracture, varus force in extension and varus force in flexion. So when there is a varus force in extension, it will be a sagittal plane fracture with medial condyle, apex medially. You can just treat like, give traction and it will fall in place, put a medial buttress plate and out. But the second fracture, lower down, it is a varus flexion mechanism. This is very common. Everybody must be seeing this fracture very common in their practice. This will be a complete or partial medial condyle, means coronal plane either or a complete medial condyle with posterior apex, with posterior impaction, with subluxation of the knee joint. You can see knee is dislocated, but you can always observe this. The femur will never leave the medial condyle because medial capsule and medial meniscus has very strong attachment with the femur, as well as the MCL is also on the medial condyle. So what happens is, medial condyle stays with the femur. Even a posteromedial condyle, then posteromedial fragment will stay with the femur. That is the rule by and large. 99.99%. Rarely you will see medial condyle out of the femur. Not. It will not. It will be, posteromedial condyle will never leave the femur. And what will go out is lateral condyle. So always there is impaction and compression on the lateral side. And this is the pattern of injury. Varus flexion mechanism, we can understand this. Right? So now, if it is treated same as a varus extension for fracture. So medial side hockey plate is applied and anteroposterior leg screw used to hold the medial condyle apex. See the outcome. Dislocation not reduced, right? Varus is there, subluxation is there, lateral condyle is totally out of the femur, and there is a post-lateral depression. So all preoperative elements, none of them are corrected because the person did not understand this fracture requires different type of fixation. So when you see the fracture pattern, you always think about it, that what type of the force and what type of fracture this can cause. You reverse the forces and you make all the things reverse. How can you reverse? Where to put a plate to reverse this? Then it can prevent the secondary displacements and get a perfect outcome. So this is how we go for a tibial condylar fractures. So we have to understand it is a varus flexion force or varus extension force. Posterior apex means varus flexion force. Now, this is the article. I say everybody, please read. Please read. This will open your eyes, I tell you. This has opened my eyes also. One day I got this article from my friend and I go through it. And as I went on reading it, I could place all the fractures in one particular type he has described. Perfect, perfect. Sin Ming Cheng, I am a great fan of him. And it's a fantastic article to be learned. Computed tomography based morphological classification of tibial condyle, medial tibial condyle, type 4, Salzger type 4, right? So this group 1 and group 2. So group 1 is a classic medial condyle fractures. This is only medial condylar involvement. And group 2 is a medial plateau fractures with lateral plateau extension, right? So we will see now types and we'll see one by one all types and we'll see the examples. So this is the classification. You can read through the article. It is easily available on Google. Just write this thing and you will get article download on the computer. So this is anteromedial condyle. Anteromedial condyle, it is a hyperextension injury. Beware of this injury. When you see this, always look for the PCL substance tear and vascular injury. So don't be hurry to operate this patient. Confirm, check for the distal pulsation, wait for 1 or 2 days, at least minimum 48 hours. If there is no vascular event, you can confirm it by even angiography. Then and then you operate. Otherwise, you may have patient have secondary thrombosis after surgery, 3rd or 4th day, and you will be in trouble. Because you will be in trouble because you operated anteriorly and the patient has got vascular problem distal. Pulmonary artery thrombosis. I have seen the cases. So this is anteromedial condyle. You can see this 3D CT images. There is nothing posterior. The whole condyle is fractal line is there, which is whole in anterior half. So treated from an anteromedial approach and elevated. It is tricortical graft or a block or a chronos, proper filling, elevation, and anteromedial buttress plate. And you can get a perfect outcome. Otherwise, patient will have hyperextension deformity. This injury has occurred by hyperextension injury only. I asked the patient, he was running and there was a fall in a ditch, there was a pit on the road and he put the foot on this and he got hyperextension of the knee. When he came with hyperextension 10 degree. This is another case of posteromedial condyle with bony, PCL bony avulsion. This is the 3D CT. This is coronal plane fracture of medial condyle. This is posteromedial condyle with PCL avulsion. You can observe that. And there is an ACL also avulsion. So ACL, PCL both are there. We have done posteromedial plating with PCL bony fixation with the screw. ACL was left alone as hyperextension of the knee was possible post-operatively. So I did not fix up the ACL. And at 6 months, full function and perfect outcome with union of the fractures. ACL also united in this way. Now another one, this posterior medial condyle, ACL and posterior condyle infection. Posterior condyle infection, right? So it is a large chunk of the medial condyle, corona plane. PCL is a part of posterior medial condyle. You can see here, PCL is a part, it is not a separate fragment. And ACL is a separate fragment, large elevated from the crater. So here we did posterior medial approach and picks up the ACL from anterior patella splitting approach. You can see the right lower figure. There is a scar, 3 stitches. They split the ligamentum patelli in midline, and you can see the ACL fragment in front of your eyes. You can fix up from that. So I have fixed on ACL fragment from that approach, and posteriorly there is a plate for posterior medial condyle, and 10 months follow full function and functional outcome. Now this is type 5, comminuted medial condyle fracture with subluxation of the lateral condyle. Right? This is only medial condyle fracture. See, medial condyle has 3 parts, anteromedial and posterior medial has another 2 parts. The large one part occupying the PCL bony attachment with this. This was a comminuted fracture. He is a Ranji Trophy player from Surat, cricketer. Oh, he is a young chap, 27 years age. And this is the injury. It was a bad, totally shattered medial condyle fracture. So now what to do, how to plan this? So I said that anteromedial condyle is almost not totally out from the cortex. So it is in line. So what is my template? Template will be anteromedial condyle. So I will do first anteromedial condyle here. Get in line with the shaft. Perfectly all right. Reduce the subluxation by giving traction and reduce it. Sometimes this type of subluxation will have lateral meniscus impacted in the this depression. So what I just give traction. If it gets reduced, that is fine. Otherwise, you get MRI done and confirm it, and you have to repair that meniscus getting out of that fracture site. So I have done that also, but in this case, it was not the case. So we could reduce the joint after traction. So we went anteromedially, percutaneous approach, and percute one with logger plate. So I reduced the anteromedial condyle first. Then I went prone position posteromedially. I reduced both the condyle over the anteromedial condyle. So this is anteromedial. You can see percutaneous plate, right? That's slided, and then posteromedial large incision, the medial plate and posteromedial plate. All 3 plates on medial condyle only, and there's the reduction and fixation. You can see a very good alignment, no varus, and perfectly done job. And you can see the heel scar. You can see full function also. And patient, because he was a cricketer, he wanted the plate to be out. So he removed the plate after 1 year. The one screw was broken, so could not be removed. But he is almost back to the game. But he cannot play as he was playing before because he has got damaged articular cartilage, gives him some pain. I have seen him recently after 4 years of treatment. So this is the outcome. But articular cartilage, once it is damaged, even if you reconstruct very nicely radiologically, he can have some fibrocartilage formation and he can have something restriction in a functional outcome. It can never be 100% normal, maybe. But he has got an excellent full range of movement and stable joint. Now group 2. This is total medial condyle fracture with partial lateral plateau split. This is a different group. This is medial condyle, which involves the lateral condyle also. So first type, you can see left upper corner. That is total medial condyle fracture. But intra-articular, it starts from a lateral condyle. So if you see the X-ray, you can see it is a medial condyle fracture. But if you see intra-articular, it is lateral condyle fracture. So intra-articular lateral condyle, but separated from medial side, medial apex. Apex is always medial. I will show you the case also, how we managed it. So this is a classic fracture. You can always see that. This is, you have to recognize this injury pattern. This is intra-articular lateral condyle, but actually a medial condyle fracture. Because fracture line is lateral to intercondyle eminence through the articular surface of the lateral condyle. And another 2 group has a medial condyle fracture with posterolateral condyle fracture. So one group has a total medial condyle fracture with apex medial or posteromedial. One group will have classic coronal plane posteromedial condyle fracture with posterior condyle fracture. So it is the posterior bicondylar tibial fractures. It is described by Potogny. We will show that also. Somebody else has described this pattern. So this is fracture line lateral, apex medial. As this fracture line moves medially from lateral condyle to intercondyle eminence and medial condyle, the apex will move posteriorly on tibia. This is what happens actually. So when it happens, as the knee gets flexion during injury, so more the flexion, more the apex is posteriorly. And posterior bicondylar tibia is classical for activa. I call it as activa fracture. Most of the patient, whenever I ask them which two-wheeler he or she was driving, it is activa. And most of the time it is female. They drive very rough. So they get a lot of injuries. So usually every month I get 2-3 young female for this type of fracture. They get a lot of injuries. So this two-wheeler injury, they have no guards, no protection, and they are driving when the knee is flexed about more than 70-80 degrees. They get this type of injury, medial condyle coronal or total with posterior medial apex and impacts on the posterior condyle. So as the fracture line moves medially, apex moves posteriorly on tibia. And this is posterior coronal plane fracture. Apex is always posterior, right? So this is how the things happen. And in all this injury, ACL is a very, very common factor. It is at about 87 to 94% incidence of ACL with this condylar fractures. Because unless the knee goes posteriorly, this injury cannot occur because the femur banks on that posterior part of the knee. So it evers with the ACL. And this, when the femur banks it, it causes shear fracture of the medial condyle as it is not in line. But the tibia, lateral condyle, posterior part is in line with the femur. So it causes coprosal fracture. This is how the injury occurs. If we understand this, then we can understand the fracture very well, fracture geometry very well, and we can plan our treatment and plates properly. So this medial condyle as an anteromedial part, posteromedial part, and medial part. All the three types are there. Then it occurs in the practice also. So when there is anteromedial, you put anteromedial plate, posteromedial medial plate, and complete medial condyle with exact medial apex, then you put the plate on border. This is Walpist has described A, B, and C, but he has not mentioned anything about the apex. He has just mentioned type A through medial condyle, sagittal plane fracture, type B through intercondyle eminence, B fracture, and C through lateral condyle, medial condyle fracture, but not mentioned where the apex goes, because as the line moves anteriorly, type A usually cannot have anterior anteromedial apex. It can definitely will have a little bit posterior apex. So this is, I am talking about type C fracture of Walpist. This is medial condyle with through lateral condyle fracture and lateral condyle subluxated out of the joint. So, but medial condyle has remained with the femur. So what is the template? Template is medial condyle. You have to reduce the lateral condyle to the medial condyle. So I took this case on fracture table only. Tied up, got the reduction, held with the clamp, put one screw from lateral to medial side, and then medial buttress plate. Percutaneous, everything percute. You could manage to do that. So this is how the fixation and everything was done. Now Potogny has described this, I told about it. He was described this fracture as a posteromedial fracture dislocation. This is coronal plane bicondylar tibial condylar fracture. So it is a posteromedial tibial plate fracture, posterocentral lateral tibial plate fracture, there is posterior condyle. And avulsion fracture of the ACL is very common with this, always. Posterior bicondylar tibia cannot occur without ACL avulsion. If it is not there bony, it is a substance. It has to go because it cannot occur without subluxation. This combination may be called as a fracture triad of posterior bicondylar tibial plate fracture. So the same injury. Posteromedial, posterolateral. All things, these are very short. I mean, posteromedial condyle is very small. ACL avulsion is there. You can see it hardly displays also. But posteromedial condyle is complete. You can see. And PCL is a part of the posteromedial condyle. I always check that. Which are the bony parts and which are the structure attached on that part. So I can make out that these are the things which are gone. And it needs how to address them. So this is impacts of the posterior condyle. You can see red line. The circle is this ACL avulsion, and green arrow, this is a posterior condyle. Operated by posterior middle plate, and ACL avulsion with this screw. Posterior condyle was also elevated. Now another one, medial condyle fracture with posterior apex, ACL, posterior central lateral condyle. You can see this. Same example. ACL, A is ACL. Medial condyle is complete with medial and posterior apex. And this is the pattern. So complete medial condyle with posterior condyle infection with ACL, right? This is the ACL. This is the injury. This white picture is the injury. Always try to make it like that. For when you see 3D CT, 2D CT, study well and then understand it. So operated by posterior medial approach and this perfect outcome. The two plates are used from same approach, extended posterior medial approach. Posterior medial and posterior both are done and got a good result. Another one. Medial condyle fracture, complete medial condyle with depressed posterior condyle. You can see split depression fracture of the posterior condyle with ACL in the central part with a weak fragment. So operated by posterior medial approach, posterior medial plating is done. Now the lateral condyle, if you see, it is split depression fracture. So cannot be addressed from posterior medial side. So I went posterolaterally. So simultaneous posterior medial and posterior approaches are taken and double plating was done. Posterolateral separate, posterior medial separate. And there's the postoperative X-ray follow-up. This is pre-op X-ray and you can compare perfect reduction. So it needs direct fixation and reduction of the fracture and fixation. Now Carlson has described this 2006 article, posterior bicondylar tibial fracture, anterior cruciate ligament injury, and he has mentioned that posterior cruciate ligament also goes down and it is a part of posterior medial comminution. So both the cruciate ligament, this is basically a soft tissue injury with bony part is also included. So most of the people have described this as a single pattern injury, but the Sin-Min Chen has a completely the composite classification given, which includes all the fracture types of the medial condyle. This posterior bicondylar tibia, this posterior medial fracture, and there is the posterior fracture. There is no fracture anteriorly. So operated by double posterior medial and posterior approach, double plating was done. And that's the outcome at 2 years. Young chap. So if we understand this well, then you have to go directly posteriorly, take a double approach and do it. If posterior condyle is around the fibula head, then you cannot do from posterior medial side. If it is a medial half of the posterior condyle, then one can do from posterior medial side. Otherwise, around the fibula head means you have to go posterior. This is the follow-up. Now this posterior medial condyle, posterior condyle and AC level. Another case. See this posterior medial condyle. But here the fibula head, you can see the fragment around the fibula head is intact. Super. So I can do that here from posterior medial approach. So I did this case from single approach. So posterior medial PCL is a part of the posterior medial condyle. You can see this yellow arrow. That is the impacted posterior lateral condyle, and medial red arrow are coronal plane posterior medial fracture. And A is ACL, P is PCL. PCL is a part of the posterior medial condyle. So this is how I always draw and make in my mind that these are the things, these are the fragment which is attachment, and these are the, so you understand it well. Understanding is very, very important. Reading the CT scan, 2D CT, 3D CT combination, combine that what is seen in 2D CT, where it is in 3D CT. So you can plan out, you can reduce all the fragments properly in position. Now, how will you plan? So first I will go posterior medially, then I will reduce posterior medial condyle. Unless you reduce posterior medial condyle, you cannot see posterior condyle because the whole thing has come posteriorly and tibia is anteriorly. And posterior condyle is with the tibia, posterior impaction. So you have to bring the tibia posteriorly by putting a plate from posterior medial side. So once you correct that translation, you will be able to see posterolateral condyle after fixation of the posterolateral condyle. So first reduce that, then put a plate. First screw at the apex, then rest of the screws, right? Medial condyle is over. Now go posterolaterally, elevate it, put up. If you elevate articular surface, you have to fill up. So fill chronos or bone graft. I use always chronos, and then put a plate. Second plate in a buttress board. 2 screws down, 2 screws proximal and distal. That's all. And this is the same picture. And ACL was able, so we fixed from NTS side with Herbert screw. Now you see this injury. Total medial condyle fracture with apex posteromedially, impacts of the posterior condyle and subluxation of the tibia laterally. So it is always anterolateral subluxation of the tibia with femur remaining on the medial condyle with apex posteromedially and lateral condyle femur ditching the posterolateral part of the lateral tibial condyle plateau. This is the injury exactly. This is how we describe it. And sometimes this compression of the lateral condyle femur cause split depression fracture of the posterior condyle. So you will see posterolaterally there is a one cortical piece. You can see here in the CT scan, right lower side, right? So this is how the injury can be understood and described. Now, this is the injury, right? This is how medial condyle with posterior apex and everything. They are 36 pictures. We operated with posteromedial single incision. We did medial, because medial condyle has a large apex and large condyle was there, we did double plating. So medial plate as well as posteromedial plate, then posterolateral plate, it's all through the same approach. And he has a full function. And good articular reconstruction, elevation of the posterior condyle and with the filling, and then this is almost 1 year follow-up. This is another case. Now, see this injury. This is posteromedially, medial condyle is again split posteromedially with a large piece, which is containing PCL also. We said as ACL, PCL, and medial condyle. All three elements are there. So we fix PCL with one plate, medial condyle plate, and ACL with the screw. So everything is reconstructed. So we have to always see and check which are the elements in the fracture, and we have to reconstruct accordingly. No big implants here. These are the function, perfect outcome. Small implants, 3.5 always. No 4.5, no 6.5. So as far as possible, avoid it. Sometimes you need a big condyle fractures. I have used, I will show the cases. Now, this is classic injury. Posteromedial fracture dislocation of the knee joint. You see, whole medial condyle with the femur and a whole lateral condyle with the shaft is out. So here again, I say always check for lateral meniscus and entrapment. It was not there in this case, but it occurs very frequently. The incidence is very high of getting lateral meniscus tear and injury. So first, always take a traction X-ray. You will get an idea. If it is displaced inside locked, then it will not get reduced. Otherwise, it will get reduced. So this is the injury. What we did first, posteromedial plating is done, but put the apex. Then I got intercondyle reduction and put intercondyle screw because both the condyles are very large. See, I'll go back again. Large medial condyle total piece, large lateral condyle. So I wanted to get a compression. So I compressed both the condyle, while with the clamp, and then part the wire, and then got one screw. Then got the rest of the screws on the medial side, and see the outcome. Perfect. So grotesque, very bad looking injury, but it can get perfect outcome. So if you understand this very well, we can plan our treatment very well, and we can get a good outcome. Now, this is something I'm telling you, this is different. This is medial condyle fracture with double apex. This is CT scan. This has got two apex, medial as well as posteromedial. This is a broad condyle, U-shaped. So this is total medial condyle fracture. Usually this fracture is through the intercondylar eminence. ACL is always there. Sometimes mild posterolateral impaction is there, sometimes may not be there. But this medial condyle will be total. So this is the injury. And you can see this total medial condyle with double apex. Anteromedial is there, there is a red apex. Yellow arrow is a posteromedial apex. So this is the injury. And you can see this total medial condyle with double apex. Medial, anteromedial is there, there is a red apex. Anteromedial is there, there is a red apex. Yellow arrow is a posteromedial apex. Medial, anteromedial is there, there is a So this round. So this condyle, if you do only posteromedial plate, this condyle will go into varus. And you can see this posterior impaction also mild. This will go into varus. So you have to hold this into valgus and then you fix the posteromedial plate. I will show you. The first posteromedial plate, correct postero-anterior alignment, right? Translation. So put only one distal apex screw, but don't fix proximally. Once you correct this, now you correct the varus. And put intercondyle screw, because here you need intercondyle screw. 6.5, so I always use this. Medial condyle to lateral condyle, right? Then rest of the screws, proximal and distal. See this. I have used posteromedial plate and it has gone into varus. Red arrow, varus is there, right? Now I will use a joystick and correct the varus. Now you can see the medial apex. It is corrected completely. And put intercondyle screw. This is done, right? Rest of the screws. And that's the post-op X-ray. No varus. It is perfectly reduced very nicely. Perfect fitting. Another one. Same, similar fracture. I must have done more than 10-20 cases. Must be. See, same fracture. There is a comminution here, medial side. And you can see there is a comminution posteromedially, medially, and there is a condyle is tilted posteriorly, and this is rotated condyle. So in AP, it looks that it is reduced, but in the coronal plane, it is rotated. So you have to reduce this apex. Again, same. Reduce posteromedially first with plate, put screw at the apex, intercondyle screw, and the rest of the screw. Let us see how it. See the comminution at the apex, right? So first posteromedial plate, I corrected that medial wedging. You can see that. And that apex part is corrected. Valgus is achieved. Put intercondyle screw. Always intercondyle screw from lateral to medial. Not from medial to lateral. You can see my screws. See, previous case also I will show. Lateral to medial. Right? Don't go medial to lateral. Medial to lateral screw will, if you use the washer, then it will compress the MCL also. It will unnecessarily damage your MCL fibers. So put guide from medial to lateral, but put the screw from lateral to medial. That's the rule. Always. This intercondyle screw, rest of the screws, right? So same way, and you can see this. No varus, full movement, perfect outcome. So if you understand this, that this condyle needs double plane fixation because there is two apex. You can use medial plate and posteromedial plate, double plate. But I wanted to avoid one plate on medial side. So no dissection on medial side. Just got corrected the varus, put one intercondyle screw. That is the better way to do it, I think. So this is very good. I mean, you can do like this. So you can avoid one plate. So you can reduce the number of implants also. The costing also reduces. Now one more. Okay, similar fracture. All are. This is total medial condyle with classic double apex. See, this second picture shows medial apex, third picture shows posterior apex. So double apex, again round type of condyle, lower down. Impacts of the posterior condyle. Again, you can see posteromedial plate, then correction of the varus with the joystick in the first picture, IIT movie picture. Then maintain the correction, put the proximal screws, and then put intercondyle screws. Two plates, posterior and posteromedial. See the post-op X-ray. See intercondyle screw. Two plates and full function. He has full function. You can see the pictures, clinical pictures. This is 6 months, 8 months follow-up. Single approach only. Everything from one approach. Posteromedial approach, prone position. I could get posteromedial, posterolateral, and intercondyle. Now this commuter medial condyle type 5, anteromedial and posteromedial condyle, and this is posterior condyle impaction. Right? This is the injury. Right now we have studied that this is medial condyle is two parts, anteromedial, posteromedial, and this, right? Now what the surgeon has done? He has done hockey plate from medial side. So subluxation, varus, wrong plate on wrong side, posteromedial condyle not reduced. You can see the posterior apex totally out and posterior impact, impaction not impact. So We corrected it. This is I received at 65 days. At 65 days, removed medial plate and corrected everything. You can see we have achieved varus correction. You can see these pictures, medial plate and posterior plate. Revised everything and got everything right. Just only thing we could not address posterolateral depressed infection that we have left. But this is what we could achieve at 2 months. So if you understand the factor very well, you cannot do these mistakes. So this is very important. Here, this man required anteromedial condyle first reduction with the shaft and then posterior plate, and see through MCL splitting that intercondylar intra-articular reduction of the medial condyle is perfectly done. You can put posterior one screw also and then put a posterior plate. But this could have been addressed very nicely on day 1. And that's the follow-up at 6 months. You can see perfect healing without no secondary collapse, and he is doing very well. I don't have clinical picture, but he has almost got 100 degree of flexion and no flexion deformity or nothing. Now, management changes with time. The left side picture is a book picture from the Surgeries 1987. And see, this is classic. We have seen that medial condyle with the femur, lateral condyle totally subluxated, and lateral condyle has gone in between the condyles or posterior condyle, right? So upper picture from the shaft, and you can see medial plate was used, intercondyle screw were used, but posterior apex is not reduced. You can see that a yellow arrow. The similar injury we have our case, and we have used one posterior approach. PCL was there, so PCL is fixed, CT scan is there, so and fixed this way. So it took 30 years to change the plate from medial to posterior surface. That's how the understanding changes. This is science. It is ever-changing science. Every time, after a few years, the concepts get changed. And that is, I will say it is a progress of the science. Consider that way. So when there is a coronal split in the posterior plateau, look for a depression or a split in the posterior plateau as well, always. Keep the knee extended while you do posterior plateau reduction and fixation. Medial condyle gets reduced in extension only. If you flex the knee, medial condyle will get displaced. So keep the knee extended when you do medial condyle plating, anterior or posterior. Isolated posterior condyle is rare injury. It is always associated with ligament injuries like ACL, PCL is the rule rather than exception. Medial condyle fracture is part of fracture dislocation injury of the knee occurring due to varus force with posterior shear in flexed knee joint. CT scan with 3D reconstruction is the most important diagnostic tool to understand this type of injury and planning treatment. This is algorithm. You can take a picture of this so you can have an idea. I have made this algorithm that how to go about. So when the coronal split is either anteromedial, direct anteromedial approach, posterior, then see isolated posterior condyle, direct approach, ACL, PCL, then also you need fixation. Associated posterior condyle, then you have to plan. Rim broken, then posterior dual approach around the fibula. If rim is not intact, then clearly extended posterior approach and fixation. Then total or subtotal medial condyle and no coronal split is there. Then apex is medial, direct medial fixation. Apex is posterior, varus tilt, dual plate or dual plane fixation for medial condyle. See the apex, double or single, and then according. Associated posterior condyle, go according. This is I have made this algorithm. And ACL fixation through anterior transverse approach. So this will, rough guide that if you, whatever you see, you just write down and then you can have an idea what to do. So you must have taken the picture, so I will go again ahead. So now we'll go for posterior condyle, right? Time is there, okay? I can continue. Hello.
Yes, sir, please.
Should I continue?
Yes, sir.
Yes, sir, please.
Okay. Posterior condyle fracture of upper and tibia. It needs direct posterior approach. We have to do it different to change the outcome. If you do different, then we can get the change the outcome and get functional outcome like this. So they need fixation. Posterior condyle makes about 10 to 15% of the cases of total tibial condyle fractures, 10%, about 10%. But they make the knee unstable. So, and patient will have mid-flexion instability. So, and later on, secondary reconstructions are difficult. So, primarily, if you address it well in young patients, they do very well. It's a simple approach actually. So, it is a diversifying nature of lateral tibial plateau fracture. So, you can see different type of the fracture. It can be a only depression. It can be a split depression. It can be just split like this. It can be a central depression of the posterior condyle. It can be sometimes vertical shear type of fracture with fibular head fracture. And it can be just an increased slope in an old age patient. An osteoporotic fracture, you will see that there is excessive increase in the slope of the posterior middle condyle because of the impacts of the articular surface. And they just get down. And if I have seen that if you do mid-flexion valgus instability, it will go in completely valgus. So they also need elevation and support. So for that, it is a new post-lateral approach for treatment of tibial plateau fractures. So this applied anatomy to be understood. You will get posteriorly in this approach only 7 centimeters of the space to work on, but you don't need more also. This is enough space to put a 2 or 3 hole plate, T-plate 3.5 mm for buttressing and fixing with the shaft 2 screws and proximally 2 to 3 screws underneath the elevated plateau. And you can do everything through this approach for posterolateral condylar intra-articular fracture. Okay, we will have to encounter genicular artery. We have to see anterior artery. Genicular artery can be cauterized. Sometimes it is mostly when the fibular head is fractured, it is ruptured. So you don't see that. But anterior artery is must to identify because you slide the plate underneath and common peroneal nerve, you have to see it. You don't have to handle it. If you handle it, it will be partial. If you see it and leave it, it will not cause any trouble and problem because actually it is not in the operative field. It is on the way to the field. It is far, far away from your operating field. It is quite lateral and you are operating quite medial. You are medial to fibular head, the nerve will go lateral to fibular head. So this is how the plate is there and this is how the vessel is there. You can see that picture. Okay. So this is, we'll go with the one illustrative case example and then we'll go further. This is 21-year-old female, left knee joint injury, 15 mm depression of the articular surface with posterior split of the cortex like this. There is no fracture anterolaterally. There is no fracture anteriorly in 3D CT also. You can see large posterolateral split and large depression of the almost whole condyle, but sloped posteriorly. So it is depressed facing posteriorly. So left side thigh, right side calf, direct posterolateral approach. From the start, just proximal to proximal popliteal crease, about 2 centimeter proximal to crease. Always take a little bit larger incision so you can identify the structures well and then dissect well. Because you need a very small window to work, but you take a large skin incision. So about 10 to 12 centimeter incision. Cut skin and subcutaneous tissue gently. In thin patient, if you use boldly, you will definitely cut the nerve. So be careful. Cut skin and subcutaneous tissue, only that much pressure should be given. And identify the nerve underneath the fascia. Roll it, that this is the nerve. Then dissect the fascia from distal to proximal. Just make a small nick distally and run your finger. It will separate the nerve completely. You don't have to use artery forceps to isolate the nerve. Don't use the rubber band to isolate the nerve and all these things. And don't put any retractor on the lateral side. This is the nerve, isolated. Okay. Now, lateral gastrocnemius and common peroneal nerve. You have to see it, that's all. Now, you identify soleus on the head of the fibula, posteriorly, right? Erase the soleus completely from the head of the fibula with knife and forceps. Hold the fiber for the forceps, cut with the knife. Make it totally white. So no fibers are left on that. If you erase the soleus completely, it will be very easy to identify anterior artery and you can go directly posteriorly on the cortex. Now you are entered. So you erase soleus, put your retractor, I have put a spike on the medial condyle also. You can see that. And you can see split depression fracture. we will see 3D CT correlation. This is split of the posterior condyle, and this is depression of the articular surface, right? So you have seen both. Now elevate the condyle. Once you elevate the condyle, put 2 K wires from lateral to medial condyle, passing underneath the elevated condyle. So it will support the elevated condyle, and you can check the reduction. There is no fear of putting the wires because vessels and nerves are posteriorly, and you can easily see the wires through the fracture site going under the elevated condyle. So this is how the wires are put, and you can see, check the reduction, completely elevated condyle reduction. There is a void beneath the elevated condyle. Now put a plate, fill up with the chronos, and you can see the reduction and fixes with the T plate. And plate is in position, right? Plate is, distal part of the plate is underneath the anterior artery. And that's the closure. And that's 4 months follow-up, full function, no pain, no issues. So if you understand this fracture well, again, approach understanding, it can give excellent functional outcome. Now, this is the X-ray. This posterior condyle can be easily missed if it is impacted. See, this is the fracture, right? X-ray. We have to suspect there's something wrong. Get a CT scan done. It is complete, depressed, impacted posterior condyle fracture. You can see that, right? So if you don't do CT, you will directly, you can easily miss this fracture. And then patient will have later on posterior condylar instability. So how will we this? Suppose somebody says that I don't want to go posteriorly. I want to treat these all lateral condyle fractures from anterior approach only. So one can definitely do that way, no problem. So you have to break the anterior condyle, anterior column which is not fractured. So this column is open, okay, opened up the condyle, okay, elevated, submeniscal arthrotomy done. So you can see the fracture also, that this is the fracture. So you can elevate the fracture. After elevation, you have to put a plate. So you put raft plate, because there is, in this approach you can use only this plate. So this plate is put, and none of the screw will support this fracture around the fibula head. So if you want to really do it, you can do gel screw technique. Anteroposterior screws can be used, but you are never sure that posteriorly hold of the screw because they are in the fracture fragment. So they might not support the fragment very well. So all these things, ideas are not wise to do. It's better to go posteriorly, see under your vision, under with your eyes, and elevate and do it. So better will be, see, if you open up posteriorly, you can see the articular surface depression like this. Complete, you can see. Elevate, fix up. The plate will be like this on the bone model. You can see just by the side of the fibula head. T plate is there, and you can see how this is the placement of the on table also. Always put the plate exactly flush to the fibula head. Otherwise, your plate will be too much medial and it will not support the elevated condyle. So this is very important. And it will be in a CT scan like this. And this case is operated. You can see this depressed condyle can be seen white. You can, after elevation, you can see the plate, and that's the outcome. Perfect elevation, fixation, and full function at 4 months. Another one. Same. See, X-rays just give suspicion that there is a fracture in the condyle, but CT scan will show complete split depression fracture of posterior condyle. Again, see, same fracture. Just we will have a revision of the approach. Prone position, left side thigh, right side calf, skin subcut cut. Now identify underneath the fascia. Then distal to proximal fascia is cut and now is located. Then lateral gastrocnemius is located. Retracted gastrocnemius on lateral side, and you can see the soleus in the floor covering the fibula head. Elevate the soleus from the fibula head with the knife, and you can reach to the fracture. The meniscus, sometimes you can take sutures through meniscus and pull it up. So you can elevate meniscus and see the fracture depression properly. Sometimes you will see popliteus tendon also. So you have to elevate, retract that popliteus tendon also. It exactly goes with that lateral condyle at the joint line level. So that comes in the way. in a vision. So you can detect it and see the fracture. See, this is the depression. Yellow arrow shows 3D CT combination. This is the depression in 3D CT. This is the depression in an under vision. Again, elevated, and you can see the bone substitute after elevation. You can see 2 KORs also elevating maintaining the reduction. Then T-plate adjusted. And you can see this IIT picture of plate position. And that's first of X-ray. This is 3 months follow-up. Almost is getting movement. He has got full range of movement later. So this is how the things can be worked out properly. If we understand and the approach properly, fracture geometry properly, then we can do a perfect job. So direct approach is better for treatment of post-rotator tibial plateau fractures. It gives better fracture reduction, stabilization, and functional outcomes. Another one, again, one more revision. No battery. Yeah, sorry for inconvenience. So this is again a case of lateral condyle. But again, this is a post-rotator split with a depressible lateral condyle facing laterally and posteriorly. But there was no fracture anteriorly. So again, I decided to go posteriorly here. So this is marking. This is F is fibula head, I is incision, P is popliteal crease, and N is now. So common peroneal nerve is identified. Lateral head of gastrocnemius is identified. This is the anterior artery going in through the superior hiatus in the interosseous membrane, goes anterior compartment. So we have to locate it. Okay, always identify anterior artery. You don't have to isolate it. Just the structure in the bunch going with in the covered in the fat between tibia and fibula is the anterior artery. So be careful. Don't cut any. As such, we don't have to work there. We have to just slide the plate under it, and we have to work at the joint line. Elevation, and you can see pre-op and post-op X-ray. Absolutely elevation. So this approach gives adequate window and adequate space to work, and always check your reduction under IITV. Once you elevate it with the KOR, hold it with the KOR. Okay. Again, the keep knee extended in flexion, you will not be able to see the reduction. So extension and little bit traction will allow a proper reduction. Now, this is the case. It looks like that this is a lateral condyle fracture, right? But in CT scan, if you see, there is a lateral condyle fracture, but there is a posterolateral split also. So it is a lateral condyle split, posterior condyle split, the fibula is in between, and all lateral condyle articular surface is facing posteriorly. So it is a lateral condyle as anterolateral and posterolateral, both the elements, right? So this is the injury pattern. You can see, follow this arrow, which are the fragments, where they are, and how we have understood this. Now, how to address that fracture? Because it has got both elements. Okay. Now this is the fracture. Lateral condyle. Okay. This is another case. Posterolateral, anterolateral. If one goes anterolateral, this RAP plate, we cannot reduce and fix this fragment. Even if we elevate it, but there won't be any screw which is supporting it. So what happens is it will go for secondary collapse. In follow-up, this condyle will get depressed when you start mobilizing. So better to fix this first. So it will act as a template for anterolateral condyle and then do this. I think that should be the plan. And this can be done. Either you have to take two approaches. that is cumbersome. So we should have one single approach which can allow both the condyle reduction simultaneously, anterolateral, posterolateral. And that is possible only with the PROS approach, which allows to go anterolateral and posterolateral simultaneously with single skin incision. So this is PROS approach, right? So you can do double plating on lateral condyle with keeping the fibula, common peroneal nerve, and anterior artery in between, and do this. So we will see what we have done in that first case I showed, that double fracture, okay? Anterolateral and posterolateral. This is the lateral position, left side femur, right side tibia. I have drawn the femur, joint line, fibula head, tibial tuberosity, and patella. Now incision, just anterior to fibula head in lateral position, from lateral apical of femur to upper two-thirds of the leg, upper one-third to the junction, right? Long incision, 10-15 around 15 centimeters, 6 inches. Because you are going to give two big flaps. So this is skin subcut cut, but don't cut the fascia. We have to make two different windows in the fascia for anterolateral and posterolateral condyle approaches. So skin subcut cut, anteriorly, you retract the subcut flap up to tibial tuberosity. And posteriorly, you can see the nerve, and there is the fascia. So this is the nerve, common peroneal nerve, right? Located with the artery for the. Now we have dissected fascia of distal to proximal. So nerve is isolated, and V is the vessel. Anterior artery is isolated, right? Now this is anterior artery, and that is the nerve. So posterolateral window is done. Okay, we have isolated the important structures. Now through the fibula, you can see fibula is totally wide dissected. You can see that artery with the fibula neck at the. You can see that anterior artery. I am showing with the yellow arrow. Now you can see 3D CT, 2D CT combination. The depressed fracture is seen as well as split of the posterior condyle is seen, right? Everything is seen now. So elevated the condyle, depressed condyle. You can see my asterotum underneath the fragment. Elevated and fixed it and lateral to medial QR. Okay. And put a posterolateral buttress plate. Put one screw there. Okay, I have achieved the reduction. And complete plating from posterolateral to antero. ES screws. So now fibula vessel, and you can see the plate inside. Now anterolaterally, standard anterolateral approach as we are doing with submeniscal arthrotomy to check the reduction. Reduction was checked and fixed with the wrap plate. You can see the reduction. Perfect lateral condyle reduction is achieved. And there's the 10 weeks follow-up with full range of movement with the PROS approach. So whole lateral condyle could manage with single skin incision anterior posteriorly. So replacement surgeon gives knee for 20 years to old patient. So we should give knee to most of the young patients get this type of fracture. So reconstruct well for 35 years and with good reduction and fixation, even for future replacement, it will be a helpful thing. The future depends on what we do in the present. So we should understand this fracture very well. I cannot teach anybody anything. I can just make them think. So cheers to all the people who can change their minds when presented with information that contradicts their beliefs. This happens so many times when we hear something new. Thank you very much. Thanks a lot.
Thank you.
Beautiful lecture, Jignesh Bhai. Thank you so much.
Thank you very much.
Wonderful, Jignesh Bhai. We all are your fan now.
Oh, thanks a lot.
It was a pin drop silence all throughout.
I was wondering sometimes if everybody is there or not.
No one was sleeping, I assure you.
Any question to?
I have a
Sir,
question.
what is the position that you prefer for the posterolateral and posteromedial approach? Floppy lateral or?
No. Prone. Prone is always comfortable, sir.
Okay.
So you will be absolutely comfortable in a prone position. Sir, if you do it in prone, you will be fan of that. Oh, this is so easy.
Dr. Jignesh,
Yes, sir.
are there any posterolateral plates or use your distal radius plates? And if
I
you're
use this
using
radius
distal
only.
radius,
I use this radius only. But
yes,
one, I got there is a one plate they made in China. 2018 article is there. I got that article also, and that I mean, pharma also of that plate. But nobody is ready to make it because they don't see any business in that. No vendor is ready to make that plate. It's a very small plate, exactly low profile copy of wrap plate, which allows,
yes.
because of the flange, allows the screw to be put on above the head of the fibula around. So that can be easily made it, but nobody is ready to make. I have contacted a few vendors that you make this plate like this. That article has given measurements also, that you make the plate with these measurements. It's exactly copy of the wrap plate, but it's a low profile, malleable. So 2018 article is there.
The problem is
because they think that they how many
the
plates
problem I have faced is
yeah
the
please.
problem I faced with distal radius plates, the screws. What size of screws do you tell your guys to bring?
3.5 mm cortical screws, they are available up to 60, 70.
Yeah, that's the problem because most of the sets of the distal radius don't have that size.
Why? See, we get in upper and tibia fracture, everybody using 3.5 implant, right? So we have got full length screws.
Yeah, but the sets don't have the, because you see,
but when you ask for the distal radius plate, ask him to send the screw up to 70.
Okay.
3.5 cortical screws.
You
need to tell them. Otherwise, they will send distal radius plate only, 30 mm maximum.
Yes.
So you ask that, you have to specifically say them that you need a 3.5 cortical screw up to 70.
Okay.
Then they will provide it.
Jignesh sir, when there is a posterior medial approach and simultaneously you want to do anterolateral approach, then what is the position of the patient?
Lateral position, sir.
Then
posterior medial and lateral.
Yes.
Posterior medial. See, they both are working in a different territory, right? So if the medial condyle is very simple, and you want to do in a supine position, something figure of 4 or something like that.
Yes.
And if you are well versed with that, you can do with that. You can go with that. I have done a few cases like that also. But if medial condyle you need to juggle a little bit, then go prone first, do it completely, fix it, then make the patient supine and do it lateral side.
Thank you. What about sir? What about fixing the ACL? Previously, they were not recommending that if you are
fixing. What I mean, how I do. If it's a large fragment, totally elevated from the crater, and after fixing the condyle, I do hyperextension. If it is not possible, that means that it is coming in the way. So I need to fix it. If the fragment is very small with the multiple fragments, I leave it.
Yes, sir. Thank you.
Any incidence of poster after using the partial poster?
Question to Jignesh before I just do the other subject on the same thing. And Jignesh?
Yes, sir.
Any incidence of injury post partial poster?
You can see my slides?
Yes, sir. We can see your slides.
The most interesting orthopedic is debugger or buggered up bone. It's what I am going to talk about. This is the one which was reduced by traction. And then this is how it was fixed up. I am talking this is years back when the plates and everything was not there. This is many years back. So you give the traction. Once you are corrected, you fixed it up. And all these things were there. And then ultimately the two platings were done and things were held up. But now there is minimal virus. So this minimal virus has to be corrected, and it should be corrected so that the future of this patient is not marred. Now here is the one, because there was only one plate which was put. There was a virus deformity, which is corrected. This is the easiest surgery. Do not accept deformity, correct early.
Now, unfortunately, in the practical situation is, your own patient has ended up into this virus. You generally tend not to advise that correction. But if you see somebody else's patient ended up into virus like this, you'll advise this correction. It is so easy to correct. Do the tracing and see that the axis is corrected. You may have to remove a small wedge, and that is how it is corrected. All this is how in 4 years' time everything is corrected well, and the things become all right. And he has a much better chance for the future to avoid any of the complications. End result of a deformity. Again, a viral deformity, which is corrected. Now here my warning is, you take these corrections, you take these lines, and you take the wedge and do it. But now, since your wedge is going to go through this highly dense bone, this is the one which is more prone to non-union. You'll have to obviously do the fibular osteotomy, correct the virus. And I feel that you got to see that it is under a compression and put in a bone graft for whatever it is, because this is the one, it takes very slow to heal up because of the sclerosis. Unfortunately, this is the only place where the deformity can be corrected. It can't be corrected higher up because otherwise it will create a S-shaped curve. So now osteotomy through this sclerosed bone will create a non-union at the time, so rigid fixation so that it can be mobilized on day one. Now here, why this deformity occurred? Medial fragment is almost 2 pieces fragment and should be corrected first and anatomy restored on the medial side. Now this is what was not being done, and this is how the whole thing ended up into, but this is many, many years back, which hardly ever happens today. On the reconstruct that lateral segment which is crushed and depressed. And this is the only way in which you can crush it, you can elevate it. Now this is what we do it. Now you see this is the CT scan. This is how the double plating is done. And now here is the case where the 99 this is badly shattered tibia. Initially comparatively easy treatment, and the surgeon just chose one screw and everything is haywire. And this is how he was. So much flexion deformity, only this much flexion. This was the deformity, 4 months, unable to walk, and pain. This is at that time I am talking about. CT scan was done. The osteotomy to correct the flexion deformity, intra-articular malalignment is the issue. Break the malalignment and realign and leave it alone. Now, all this was the situation which was there. So I judged it that intra-articular, I do not want to do anything because this is the one which appears to be reasonable. So ultimately, this is the one which, as you can see, the surgeon is treated with the skeletal traction. So now this is not a functional, it needs correction. 4 months it is difficult. And you do the tracing, you can see this is overflowing. So you will have to do the osteotomy and you will have to shorten this. So this is how the tracing which is done. You're doing the tracing. Here is the fracture which is separated out. So here is that piece which you have to venture translate on the tibia and traction at the tibia, rotation of the tibia. And the axis is like this. So here is the one which you have to correct the axis. So this is where I have now drawn 7 centimeters from the knee joint. Having now done that, this is how it is. You will have to rotate it. So now you establish the tibia. You establish the tibia by rotating this lower fragment. And now this proximal fragment you will have to reduce and probably screw it. And this is the one which you'll have to bring that. So now this is how you're going to do it. This is how you got in all directions you got this situation. Now once you put the plate, here it is going to be a gap. When you put the plate here, it is going to be the gap. So defect is graph. This is AP view. Defect is graph, and see exactly that is what has happened. This is what was there. This is the one which was grafted. This is how it is corrected. And then
0 to 60-degree range of movement. This is after taking out the things. This is how it was grafted here. And this is the range of movement. That is, the knee was straight and it was so much of the range of movement was there. This is the one which could be, if ever a TKR is needed in the future, you could do this TKR. This is not a very good result, as you all know, but in such a situation, there was nothing much which could be done. Probably even today, if I was doing it, I would have done this osteotomy and I would have corrected it. But still, whether I would have got any more movement, I'm not 100% sure. Surgery went as planned. Intraoperatively, knee could not be flexed. And then grudgingly, I had to do a transverse osteotomy of the patella. I'm not sure whether it was a right thing or a wrong thing at that time. This is many, many years back I'm talking about. This is the case. As you can see, this was a malunion, CT scan. All you can see it here. Now, this is the epicondylar osteotomy. So this is the one, once you do the epicondylar osteotomy, the things become clearer. So this was the epicondylar osteotomy. Once the epicondylar osteotomy was done, you were seeing the malposition of the tibia. So now you could adjust it. Initially, you elevate it and transfix it with the K-wire. So now you elevated it and transfixed with the K-wire. You can see it here, you are keeping it elevated and transfixed with the K-wire. And then you fix it up. This is how it was. This is how ultimately it was fixed up. This is the osteotomy which was there done. This is how ultimately the knee could be corrected. This is how it was, the picture. This was in 2 years' time, the range of movement was there. So the arthroscopic release was done. And then the good range of movement was ultimately observed. But you can see this is still small amount of defect has remained. Here was the Abdul Neem. This is how it was a malunion. And surgery had treated like this. Patient had needs the maximum surgery to correct minimally invasive surgery. Now, this is the patient who had a pain, and you can see this is overlapping of the tibia which has occurred on the lateral side. So you had to plan this out. This is the CT scan. You can see the CT scan. This was the CT scan that was found, and 4 months after the fixation walks with a painful movement. This is how it was. So you can see so much was overlapping. So basically, the plan is, this is where it is held up. So you take this out, fibrous tissue which is there, and put this tibia back. Try to get the tibia into line with the upper end of the femur. This is how it was planned. You can see this is the gap. So here how it was planned. So you can see this here. This is how it was done. Osteotomy was planned like this, corrected, and this whole thing was corrected. And you can see this was corrected. This is what is 3 months picture. This is the range of movement. Sida karo. Walk about. And I think here is the other case where the surgeon treated with the Alizarao because the patient had some hepatic problem and the surgeon treated with Alizarao, got infected and completely fired. Now, this is the stage where I saw. So first and foremost, the infection had to be removed, and he didn't want to now do a TKR. I offered him a TKR. He didn't accept it, so then it was an arthrodesis was done. This is how the arthrodesis was done. I had to do the osteotomy to correct the whole thing, and it healed up completely. So this, such a small fracture ended up into arthrodesis because of the Alizarao infrag infection. And this is the other case, small case. Immediately the percutaneous screws were put. This is 1 month time, percutaneous screw, and everything collapsed. Any idea why this collapsed? Anybody has an idea why this collapsed?
Share force, sir.
Hearing for posterior condyle.
Drafting is not done.
I can't hear. Anyway, I'll proceed. You can see this is what was happened. You can see now this X-ray. This is the condyle. This was the posterior condyle. The screws are in the AP view. What typical AP view screws are gone. This is how now we do the CT scan and we find out where it is. So this is how it was. A small thing. Surgeon did this. Here was the fracture. Normally we would have done this one now today after a CT scan. So you can see this is what happened, turned out to be. This was the fracture. This is the CT scan. And you can see the CT scan, the screw has gone right from outside. The screw should have gone here. There was a CT scan available. As you can see, it has gone right at the one corner and it has cracked that fragment also. The fragment has remained displaced. This is how it is. Percutaneous, there was no judgment about the center of the fracture. And this is how it ultimately turned out to be. This. So the percutaneous surgery in a proximal tibia, I feel is no. Surgeon had not done even a CT scan and he treated this patient with percutaneous purely on the AP view which he got. That purely on that AP view, he treated the patient with the percutaneous screw. In the hindsight, leave alone could have been a better than this screw. Open surgery would not have allowed this bishop because then he would have realized which is the heart of the bone through which he has put the screws. And you can see the CT scans of this patient. Surgeon was AD. I think I have already spoken about it, but you can see this is the one. Now he did this posterior fragment, tried to put it from anteriorly and put an Aliza around. This is in 2007. He did this closed leg screw without deduction of the posterior medial fragment. I think still people are so hesitant to go posteriorly and the prone position. That's what I think majority of the people hesitate to do it. So maximum they go on the medial side within a figure of 4. And when the fragment is really posterior, you cannot take it. So this is what is the disaster. It's never going to be. The logic of minimally invasive here is satisfied his ego of fixing the fracture in shortest time without posterior incision compared to me. I will do a long posterior incision and struggle for an hour to get the fracture back in anatomical position, and then only I'll put in a buttress plate. To hell with the patient. Patient's life is useless. His time is more important. That is how the surgeon thinks. Again, this is another circuit. You can see this. All these are purely the leg screws. I do not know what then minimal invasive in this sort of a situation the surgeon did it. Ultimately, after a long time, the thing had to be corrected, and this is how it was corrected. This is another one. You can see this was intra-articular fracture. CT scan is done. Everything is done. Confirmed bicondylar osteomedial fragment. Even he asked for a CT scan. But just picked up like this. Kept the medial condyle only with this percutaneous screw with this fragment right. He just tried to put this there. You know, there is no reduction. This is how I know the surgeon is a very busy surgeon. And he had done the course of this proximal tibia fracture. Still, hesitancy to go posteriorly. And that's the reason this was a shortcut he took. And this is how it was a range of movement where very poor. And you can see this is all minimally invasive. This is the surgery incision which is taken. Movements are not always affected. Pain is the issue and patient was having pain all the time. To hell with minimally invasive. Lipo is contraindicated in a joint restoration trauma surgery. You must do full surgery and twist all these pieces. Just now, I think Dr. Jignesh has taken such a beautiful talk on how to fix up all these fragments. And that is the only way in which you will be able to treat the patient. Patient continued his life, thanking the doctor for a wonderfully minimally invasive keyhole surgery. Minimally invasive is not for articular surface. It's only for a diaphyseal or a metaphyseal fracture, which can be judged in CR. No minimally invasive surgery CR based in a joint reconstruction. Unstable comminuted fracture, early surgery, neutralized medial forces for late fill up on the outer side, bone voids and graft plus bone filler. Excellent articular cartilage alignment. Attempt correcting surgery, even if it is late, do not leave it. And now, upper and tibia fractures do not need, even if you want to fill it up, do not need the autograft. It has been proved very well that either the allograft or a bone substitute does equally well. You have any comment on this, Dr. Jignesh? Have you ever used the autograph for these fractures?
No, sir, I have not used autograft. I use always bone fillers.
Yeah, bone filler. I think this is all what you need for that. So bad fractures need all tricks: reduction, graft, double plating, locking plates, extrapostiomedial approach. Bad fracture needs good surgeons, not lazy surgeons. Bad fractures need never set eye surgeons. If we do a bad fracture, what we will do? Do it into a patient, transfer to whoever you feel is a good surgeon, or call a good surgeon. I think in Surat, Dr. Jignesh, he is being called upon by quite a lot of surgeons to do this proximal tibia fracture. When I spoke, I hope you don't mind me talking, Jignesh.
Yeah, please, sir. Continue.
When I asked him, he said, sir, I am doing more. Large majority of the posterior, this proximal tibias of other people's surgery, and it is not my surgery. It is not their own patient. Only thing that is to have the follow-up X-rays, follow-up results and everything. That's the reason he has got such beautiful collection of cases. First time I heard Dr. Jignesh in Surat, I was so impressed. And then I think we called him in Robacon, and now he has become an all-India faculty for proximal tibia. He has done so many other surgeries also, but somehow he has got stuck with the proximal tibia. In Gujarat, I know I used to attend that meetings very often. In consecutively, I think 5 or 6 meetings in a paper which was purely a medal paper. He was the only one who got that 4 or 5 years in a line. And afterwards, he was debarred to get compete in those medal papers. Am I right, Jignesh?
Right, sir, right. Absolutely right. 5 times consecutive.
That's what I remember.
Thank you very much, sir. Whatever I am here because of you only. That's what I can say.
Oh, I think you deserve your place. You are wonderfully. You are treating it, teaching it. No question about it.
Thank you so much, sir. So kind of you.
Any questions? Any questions before we wind up? Okay, friends. Good night.
Yeah. Good night. Thank you, sir. Thank you very much. Good night.
Thank you, Jignesh bhai. Thank you.
Thank you so much.
Good night, sir.
Good night.